Hello, everyone. Good morning, good afternoon, good evening, whatever time that you may be listening in. I want to welcome you to today's tutorial. My name is Violet Aswakek. I'm a lecturer of pediatrics at the Kenya Medical Training College in the Department of Clinical Medicine. Today's topic, we are going to be looking at the emergency treatment algorithm for convulsions. And we shall be looking at this in two bits. We shall look at the neonate a little bit later on, but then we shall start with the child who is beyond the neonatal period. As usual, these lectures are meant for clinical medicine students, but anybody can listen in because there's no limit to learning. So we are going to be looking at the child who is beyond the neonatal period and presents with convulsions. So anytime a child presents with convulsions, the first thing as a clinician that should be done is to ensure your own safety and that of the child. After that, the next thing you need to do is to assess the airway, the breathing, circulation, and disability. So, in the airway, you want to make sure that it is well positioned. The child, should be lying laterally. That way, they will not be able to aspirate secretions, or should they vomit, they'll not be able to aspirate. Besides that, that is the opening of the airway. You also need to make sure that it is clear. That means if there are any secretions, then they are sucked. And for sucking, remember, you only suck what you can see and you don't suck directly on the mucous membranes. Once your airway is open and well positioned and it is clear, then you need to start the child on oxygen. Remember, all children with the convulsions are at risk of hypoxia, and especially the hypoxia that we are concerned about is brain hypoxia. And so you need to start a child who is convulsing on oxygen, preferably using the non-rebreather bag, because that one you're assured of a high fraction of inspired oxygen percentage. After that, once your airway is clear, it is well positioned, the child is on oxygen, now you can assess for circulatory adequacy. So you want to palpate the extremities, the hands and the feet for temperature. If they are cold, then you need to check how far up, what is the temperature gradient, how far up is the cold coming, because you want to rule out any possibility of circulatory failure. And at the same time, you also want to make sure that they are not severely pale, which would be an indication for emergency transfusion. Now, most children who are presenting with convulsions are likely to be hypoglycemic. The best practice is to usually do a random blood sugar test by the bedside. If it is low, then you make a decision to give 10% dextrose. And the dose is usually 5 ml per kg given slowly. Now, sometimes in case you're not able to do a rapid check with the random blood sugar with the glucose sticks, remember, you can also use clinical signs that suggest hypoglycemia. A child who has not eaten for the last 24 hours is likely to be hypoglycemic. A child who has been very sick and is moribund is a child who is likely to be hypoglycemic, and therefore giving 10% dextrose may well be indicated. So all these things are happening within the first 5 minutes of the convulsion, because we are not going to be giving an anticonvulsant to a child who has convulsed for less than 3 minutes unless there are other riders, as we shall see later. So within the first 5 minutes, these are the things you're doing. You're looking at the life support and they're trying to intervene. And then if 5 minutes have elapsed, then you can start your child on anticonvulsants. So we are saying that if the convulsion has lasted 5 minutes and more, then that child qualifies to receive an anticonvulsant medication. The anticonvulsant of choice is diazepam. Diazepam can either be administered intravenously or rectally. When it is administered intravenously, then the dose is 0.3 milligrams per kg given slowly over 1 minute. In case, for whatever reason, as a clinician, you're not able to gain IV access, then you can do rectal diazepam. In this case, the dose is slightly higher. It is 0.5 milligrams per kg. At this point, let me say that you need to know or familiarize yourself with how far in to insert the syringe that you're using to administer rectal diazepam. You must push the syringe in at least about 2 centimeters. Because if you do not do that, you'll end up administering the diazepam anally. And when you put the diazepam at the anal region, then it cannot be absorbed. It is the same as pouring it on the palm of the hand. So it's very important that you know how to insert it properly so that you administer the diazepam in the rectum. So the convulsion may stop. And when that happens, what do? You need to check your airway again, make sure it's still open and patent and not requiring any sucking. You need to make sure the child is still breathing well and they're on oxygen. The C is okay and they're not, they don't have any altered consciousness. At that time, then you need now to at least start taking history. You can start examining the child and also doing some investigations, baseline investigations. And if need be, if there is indication for empirical treatment, then you start. In the event that the convulsion continues after 5 minutes after you have given the initial dose of anticonvulsant, which is diazepam, then you need to give a second dose of IV diazepam or rectal diazepam depending on which route you're using. The dose does not change. If it is intravenous, it is 0.3 milligrams per kilo body weight given slowly over 1 minute. If it is rectal, it is 0.5 milligrams per kg, and remember to insert the syringe properly. Continue giving oxygen. You never stop giving oxygen because besides the risk of the convulsion predisposing the child to hypoxia, the anticonvulsants themselves, diazepam, is also a potential depressor of the respiratory center. And so that can also cause further hypoxia. So the child should continuously be on oxygen. When the convulsion stops, again, you need to check for airway and breathing, that they are still going on, the airway is still clear, well positioned and patterned, the child is on oxygen, and everything is going on well. Investigate and continue instituting your treatment, or then if your arrangements for referral are already concluded, the child may leave. In the event that the convulsion continues 5 minutes after the second dose of diazepam, that would mean that this child has been convulsing now for 15 minutes. Now you need to change your medication. We go to the second line anticonvulsant. And the anticonvulsant of choice after giving the initial diazepam is IM phenobarbital. Please note that phenobarbital is given intramuscularly. You will give it at a loading dose of 15 milligrams per kg body weight. Once that has happened, you need now to start the child on maintenance dose of 2.5 milligrams per kilo. That is a daily dosing for 48 hours, and then you review them further. Again, you continue with your oxygen administration. When the convulsion stops, again, you make sure that the airway is still open and patent and well positioned, no secretions. If they're there, you clear it, and then continue with your treatment or referral plans. Now, sometimes you may have given your diazepam and then your child is still convulsing 15 minutes into treatment. And maybe you don't have phenobarb, we have other alternatives. levetiracetam is the first alternative. And if you're going to be using levetiracetam, you're going to give a loading dose of 30 milligrams per kg. This one is given over 15 minutes as an infusion, an intravenous infusion. Later on, then you give maintenance dose of 30 milligrams per kg per day divided into 2 doses. Maintenance doses are usually started at least 12 hours after the loading dose. The second alternative to phenobab is phenytoin, and phenytoin is given as a loading dose at a dose of 15 to 20 milligrams intravenously, and that this should not exceed 1 milligram per kg per minute. Again, it is given slowly. So maintenance dose is 2.5 milligrams to 5 milligrams per kilo divided in 2 doses. And please do not give a maximum, do not go beyond 150 milligrams twice daily. So it is 2.5 to 5 milligrams per kg per dose BD. The third alternative is sodium valproate. Sodium valproate is also given intravenously at a loading dose of 10 to 15 milligrams per kilo. Please do not exceed a maximum of 60 milligrams per kilo or 600 milligrams per day. And then can be given as a single dose or 2 divided doses, preferably as 2 divided doses. Maintenance dose for sodium valproate is an oral dosing of 25 to 30 milligrams per kilo per day in 2 divided doses. Please note, do not give more than 2 doses of diazepam in 24 hours, and especially after you have already started giving phenobarbital. Do not give phenobarbital loading dose to a child who is a non-epileptic and already on phenobarbital maintenance. So you need to use the alternatives that you have mentioned. You can use levetiracetam, you can use phenytoin, you can use sodium valproate. In a child who is already on phenobab for maintenance, because they're epileptics, do not give a loading dose of phenobab. This is just to emphasize the other alternatives that are available for phenobarbital: phenytoin, levetiracetam, and sodium valproate. Now, not every child who convulses will fit into the category of convulsing for more than 5 minutes. Previously, in the last few minutes, I have said that a child who qualifies to get anticonvulsant control is a child whose convulsion has lasted more than 5 minutes. And then we said after you're given the initial dose, diazepam dose, if they continue convulsing into the 10th minute, then you give the second dose of diazepam. If they continue convulsing into the 15th minute, then they are indicated for IM phenobarbital. There are other children who will present with convulsions, but their convulsions are lasting less than 5 minutes. What do we do with them? In these kinds of children, you ask, how many times has the child convulsed in the last 2 hours? The caregiver or the mother will usually let you know. So, a child who has convulsed severally, but each convulsion has been lasting less than 5 minutes. What is significant in this situation is, excuse me, a child having a third convulsion, and this third convulsion is happening within a span of 2 hours. That means they're having short multiple convulsions. So any 3 or more convulsions lasting less than 5 minutes, occurring within 2 hours, that is a child who then can get anticonvulsant medication. So what do? You give them IV, should be IM phenobarbital at a dose of 15 milligrams per kg as a loading dose. IM phenobarbital 15 milligrams per kg as a loading dose. And then this is followed by a maintenance dose of the same, can be given orally or intramuscularly at a dose of 2.5 milligrams per kg daily for 2 days. Remember, maintenance doses usually are started 12 hours after the loading dose. This child also needs to be put on oxygen, just like the other child who was convulsing for more than 5 minutes. And when the convulsion stops, you need again to check the airway, that it is patent, that it is well positioned, that they are breathing well, and they are on oxygen. And then you need to take your history and then do your investigations and start the child on treatment as indicated. Or if you're not in a position to do that, then you need to make adequate and prompt referral. However, in a child who is convulsing for less than 5 minutes and in the last 2 hours they have not exceeded 2 convulsions, that child does not require emergency anticonvulsant treatment. The only child who requires emergency anticonvulsant treatment, whose convulsions are less than 5 minutes, is the child who is having 3+ convulsions within a span of 2 hours. If they do not meet that threshold, then they do not qualify to be given urgent or emergency anticonvulsant treatment. Please remember that. Having talked about the child who is beyond the neonatal period, let's now talk about the neonate who also presents with convulsions. In this case, we are going to be looking at convulsions, a convulsion that is lasting more than 3 minutes, as opposed to the bigger child in whom we said you give treatment to a child who is convulsing for more than 5 minutes. In the neonate, it is 3 minutes. That scenario, or multiple short seizures or convulsions. That means a seizure lasting less than 3 minutes, but they are repetitive in nature. So first and foremost, like we did with the bigger child, you do your life support maneuvers. While you're waiting to observe if the convulsion will last beyond 3 minutes, you quickly assess the airway, make sure it is well positioned and it is clear. You put the neonate on oxygen. You check for their circulation, whether they have any signs of circulatory failure. And in this case, most of the time, convulsions in the neonate will be due to hypoglycemia. So you need to consider glucose early, and also hypocalcemia, so you need to consider calcium. So in this neonate who is convulsing for more than 3 minutes, or they're having short repetitive convulsions, they are given IM phenobarbital. The dose is 20 milligrams per kg. Please note, as you can see, we do not use diazepam to control seizures in neonates. The drug of choice for seizure control in neonates is phenobarbital, and the loading dose is 20 milligrams per kg. Please do not be afraid to give 20 milligrams per kg because it may look so much. Because, for example, if a neonate is 3 kilos, that would mean 60 milligrams. Looks much, but that is what works. If you do not give 20 milligrams per kg as a loading dose, you will not achieve a therapeutic index or concentration that will be able to control the seizure. That does not take away the side effects of phenobarbital, which is respiratory depression. So you will keep giving phenobarb, and then the seizure is not being controlled, but the baby is suffering the side effects. So you need to give an optimum dose, which is 20 milligrams per kg as a loading dose, in order to be able to hit the minimum therapeutic concentration for seizure control in the neonate. Once you have done that, then you need to reassess this neonate. And the reassessment is done after 1 hour. So what will you be doing in this 1 hour? You will be taking history, you will be doing a neurologic exam and other systemic examinations and coming up with a provisional diagnosis, what do we call it? A provisional diagnosis, okay? Or an impression. So that 1 hour, those are the things you're doing, and you are going to be reassessing this baby after 1 hour. If at that time perhaps the seizure is still on, but there is no obvious underlying cause, then you need to suspect pyridoxine deficiency. And you remember when we covered this again in class, we said that pyridoxine can be used therapeutically and also diagnostically. This is the point where you use it. So you will administer pyridoxine while taking an EEG. If the EEG shows a normal firing while the baby is receiving pyridoxine, then you are making a diagnosis of pyridoxine deficiency, and now you should embark on treating. That is one scenario. The other scenario is where you assess the child or the neonate and to find out whether the seizure has stopped or not. In the first scenario, we said it may not have stopped, but then you need to consider pyridoxine deficiency. However, if the seizure has not stopped or decreased significantly, then if the seizure rather has stopped significantly, then you need to start them on maintenance phenobarbital. And the dose is 5 milligrams per kg per day, and it is usually started 12 hours after the loading dose. The administration route can either be intramuscular or per-oral. However, if the seizure has not stopped considerably, then you give a second dose of phenobarbital intramuscularly. But in this case, the dose is not 20, it is 10 milligrams per kg. So this will be happening after 1 hour, that is 1 hour after the first phenobarbital dose, which was 20 milligrams per kilo. So the second dose is coming in 1 hour later, and it is 10 milligrams per kilo. Please do not exceed a total of 40 milligrams per kilo. Like we said, the presence of a seizure will usually deprive the brain of oxygen. At the same time, the administration of phenobarbital also has respiratory depression effects. And so you must be prepared. Even if the neonate is on oxygen, anything can happen. They can go into failure, respiratory failure or arrest. And so you must always be prepared with your bag and mask and also better means of supplying oxygen should the need arise. So, after you have given your second dose of phenobarbital, you will need to reassess this neonate again after 1 hour. And then you're going to be making new decisions based on whether or not the seizure has stopped. So the question you ask yourself is, has the seizure stopped? The answer will either be yes or no. If the answer is yes, the seizure has stopped, then you start the neonate on maintenance phenobarbital. The dose is 5 milligrams per kg daily, and that should be 12 hours after the second loading dose, the 10 milligrams, and it can be given intramuscularly or orally. In the event that you find the seizure has not stopped, you need to ask yourself or find out, do you have levetiracetam or not? If levetiracetam is available, that is what is preferred. And so the dose is 30 milligrams per kg given as an infusion over 15 minutes, intravenous infusion over 15 minutes. In case levetiracetam is not available, then your other option will be phenytoin. Again, you'll give an intravenous infusion of phenytoin at a dose of 15 milligrams per kg over 15 minutes. In both cases, whether you have levetiracetam or not, whether you are using it or you're using phenytoin, at the end of 1 hour, you need to reassess your baby and make new decisions. In case, let's start with levetiracetam. Let's say after you gave your second phenobarbital dose, you had levetiracetam, you already given your initial loading infusion dose. The next question you ask yourself is, has the seizure stopped or not? If the answer is yes, the seizure has stopped, then you need to start the child on maintenance levetiracetam, and the dose is 30 milligrams per kg per day, given in 2 divided doses. Again, the maintenance doses are supposed to be started 12 hours after the loading dose. In the event the seizure has not stopped, then you need to consult a pediatric neurologist, and at the same time, you may want to consider phenytoin. In the event you used phenytoin after phenobarb, the same question arises, has the seizure stopped? If the answer is yes, then you start the baby on maintenance phenytoin, which is given orally. The dose is 5 milligrams per kg per day in 2 divided doses. In the event that the seizure has not stopped, then just like previously, you need to consult a pediatric neurologist, and also you may want to consider giving levetiracetam. That means you can have a neonate who is on 3 medications or more than 2 medications, okay, for anticonvulsant therapy. It is very important to remember that we do not give phenobarbital prophylaxis to neonates who have had severe birth asphyxia and are at risk or have developed hypoxic ischemic encephalopathy. We do not give prophylactic phenobarb. You will only give phenobarbital if the neonate is actively convulsing, not for prophylaxis. When do you stop the anticonvulsants? Number 1, you will stop anticonvulsants in a neonate who exhibits normal neurological examination, has a normal EEG, and has been seizure-free for more than 72 hours. That is the criteria. However, should the seizure recur, then medication must be reinstituted. Number 2, in neonates who have seizure control with only one anticonvulsant, then the stoppage of the medication can just be abrupt. You don't have to taper off medication when you've only used phenobarbital alone or a single drug seizure control. However, in neonates in whom you have used more than one anticonvulsant, there could be 2, there could be 3. In those kinds of neonates, then you must taper off the anticonvulsants one by one. And in that case, phenobarbital is usually the last one to be withdrawn. And of course, you are observing whether they are getting back into seizure mode or not. Once they have been seizure-free for 3 days, their neurologic examination is normal, their EEGs are normal, then those are candidates or neonates whose anticonvulsant medication should be stopped. And with that, we've come to the end of our short lecture today. Remember, in this lesson, we were only looking at what to do when a child comes in with a convulsion. We have looked at the bigger child who is beyond the neonatal period, and we've also looked at the neonate. You've seen the differences. The first line for the bigger child beyond the neonatal period, first line anticonvulsant will be diazepam, which can be given intravenously or parectally. And the doses differ. The parenteral dose is a little bit higher, 0.5 milligrams per kilo. The intravenous dose is a little bit lower, 0.3, given slowly. And then the reassessment and the second dose if the convulsion has not ended in 5 minutes. That is a little bit different from the neonate, in whom we do not wait for 5 minutes. Any neonate who is convulsing beyond 3 minutes needs anticonvulsant medication. And then the first line drug of choice for anticonvulsant control is not diazepam. Please do not use diazepam in a neonate. We do not use that. It causes serious respiratory depression. We use phenobarbital, and the loading dose is high, it's 20 milligrams per kilo. And then the difference again is the reassessment of the bigger child is within 5 minutes. The reassessment in the neonate is 1 hour. And then you make the decisions as you go along. Don't forget that. So that is the end of our lecture. And then we have not addressed the cause of the convulsions. Those are covered in another lecture. But in between, when you're waiting for the convulsion, for the anticonvulsant to take effect, before you decide whether or not to give another dose, in between you're taking your history, you're doing your examination, you're doing your investigations, you're starting the child on empirical treatment if indicated, and so on and so forth. So in this lecture, we were not looking at what causes convulsions. We were only addressing the convulsion itself, when to take action and when to hold on, how to make decisions, and how to progress once you have started. With that, I want to say thank you for your attention. Reference materials have been the MOH protocol guidelines, both for the newborn and for the bigger child who is up to 5 years of age. Thank you very much.